I'm going to turn it over first to Dr. Brent Myers from North Carolina.
Good afternoon. Brent Myers. I'm the director and medical director for the Wake County EMS system in Raleigh, North Carolina. We entered into this space in about 2009 with an advanced practice paramedic program based on our needs assessment in the community. We are now moving into very focused areas of endeavor that include mental health patients, substance abuse patients, patients with falls and assisted living facilities, and low acuity callers to the 911 system. And we'll be happy to discuss over the next hour in any detail how those go. I think the beauty of one of these lunch and learn opportunities is that you can really ask the questions and we can give the true answers of the difficulties, the failures that we have experienced so that you don't have to experience the same in your community. And we're more than happy to share not only the best practice but also the worst practice. And we look forward to a good conversation.
Dr.
Beck. Good afternoon. My name's Eric Beck. I'm at least for a couple more weeks, still one of the medical directors in Chicago for the city of Chicago, the Chicago Fire Department, and several private providers there. I'm happy to share with you all that I am making a transition, partly based on this evolving space of mobile integrated healthcare. We'll be moving to Envision Healthcare, working with both AMR and Evolution Health to develop interprofessional teams to move into the mobile integrated healthcare space and solve the challenges of population-based healthcare. Snapshot from Chicago, because that's kind of my perspective that I bring to the panel today. 3 programs of relevance in Chicago. One is about a decade old, using EMT basics paired with public health nurses and pediatricians to provide immunizations to over 1,000 children that were either or under immunized in our housing projects in urban Chicago. The second program is a private provider, hospital supported CHF readmission prevention initiative that revolved around a needs assessment for a hospital-based population with CHF. And the third program is still in its infancy, and this is a citywide dialogue, a mobile integrated healthcare needs assessment that's being conducted out of the Chicago office of the mayor, and involves a strategy to link together a variety of city services, including the EMS offered by the Chicago Fire Department.
Great, thanks. Dr. Beeson.
Jeff Beeson, I'm the medical director of the Fort Worth system you've heard a lot about today. We started shortly after Brent in 2009 and learned from all his mistakes and did it correctly. Sorry. No, that's not true. So we started, like most of you heard this morning, with our loyal customers, which branched into integrating with our healthcare system in the communities to deal with heart failure readmissions, and that then grew into frequent ED users, not particularly EMS, but ED, partnering with them, which then grew into various projects from observation avoidance, which I'm sure you heard about some this morning, to our most recent and probably biggest growing project is our hospice program. We've been partnering with our local hospice agencies. So 4+ years of blood, sweat, lots of scars, lots of oops, wish you wouldn't have done that. So learn from our mistakes.
All right. Thanks, gentlemen. I'm Ed Rock. I'm the Chief Medical Officer of AMR and Evolution Health, and I'm a mobile integrated healthcare physician. It's the first time I've ever said that.
Hello, Ed.
Hello.
Congratulations.
Yeah, and I'm glad to be here. Ironically, that's something that I think you heard a lot of this morning. I think you'll hear a lot from the panel. I want to point out a really Mr. Obvious observation here, but it's very important. Look around the room. We are at EMSWorld, where you can cut open cadavers, you can climb into vehicles, you can drill into bones, you can do all sorts of things. You can put tubes in people's airways, around people's airways, all sorts of stuff. The strobes, the light bars, the LEDs. You can smell Jet A even when it's not there, right? How many people do you think are in this room? Ginger? 315 of you have chosen to be a part of something, and here's the second part of the Mr. Obvious statement. Raise your hand if you're currently providing mobile integrated health in your community. Raise your hand. I'm sorry, maybe you didn't hear me. Raise your hand if you're providing it today. So here's the Mr. Obvious observation. 315 of us gathered in a room in a well-established profession that deals with folks who are at the extreme, and 315 folks chose to stick this concept out for a day. There's a very important message there. And the important message is this is no longer, as you heard from our speakers this morning, this is no longer just kind of somebody's idea. This is an evolving, as all of my colleagues have said, it's an evolving new practice of medicine. So someday you're going to be able to sit with your grandchildren and say, I remember that was back in Vegas. And we were in Vegas when that started. Matter of fact, it rained. They had a weed the next week. I think you're getting a weed. I think weed's coming in. That's a very important concept for where we are. So our hopes today at this particular session are really bidirectional. What we want to do, you heard tremendous presentations this morning. There are more coming this afternoon. What we want to do, we got your list of, how many total questions? Ton of questions. Yeah, lots, 50 plus questions. You all have questions, you all have observations. We have some things that we want to share, but we want this to be a very interactive session because this is not an established practice of medicine yet. We are all building it. We're all architects, we're all the builders. No one has the answer, but everyone together has a solution, right? So we're more effective as one than we will ever be as many. So the purpose of today, right now, is to realize some of that. So what we're going to do is we're going to open up the floor to your questions, discuss them. Like I said, we have some questions as well. I got a pair of really ugly roving microphone holders that we picked up on discount that are coming out. So with that, I'm going to open up the floor. They aren't the smartest microphone rovers on the planet, sorry.
Please identify yourself.
And, oh, I'm sorry, if everyone could, because I think this is an important message, who you are and where you're from.
As long as you're in the same book. Jim Swisher, San Marcos EMS. Quick question for you. We're in the middle of Holy War Land down in where we're at, and we've got the two different hospitals that are two or three different hospitals that compete for our patients, and we have a constant question about where we're taking patients, why we're taking them there. As far as the integrated health care, how do I bring that together?
If you don't mind, I'll start with that. Again, I'm Brent Myers. I'm from Wake County. And for those of you who don't know geography, that is the University of North Carolina at Chapel Hill, Duke University Healthcare System, and Wake Med Healthcare System. They get along better on the basketball court than they do as far as healthcare systems go. So when we started Mobile Integrated Healthcare in Advanced Practice Paramedic Program, it was 3 different meetings every time. You had to go meet with the UNC system, Rex UNC system, had to go meet with the Duke system, then had to go meet with the Wake system because they would not talk to one another. As we have moved through this, over the past 4 years, stealing from Fort Worth, we now have care plans for our patients that are familiar faces. And the coordinators from each of those hospitals contribute to a single committee, and that has to do with hospital destination for those individuals. So I would say it starts out really rough. And it starts out at each of those individual facilities, the competitors, and then it becomes obvious when you get below the competition level, which usually has less C and O in it and more operations, then they'll come and be helpful to you. That's been our experience.
You know what, Jim? There's an interesting parallel to your question, and I would ask the room, do you guys remember when the hospital came to you, the hospital system, the healthcare system, and said, hey, let's institute a pre-hospital 12-lead ECG program. Remember that? Do you remember when the hospital came to you and said, hey, you and EMS, you need to use end-tidal CO2? Remember that? You remember when the hospital said, hey, we've solved our diversion problem. Come on in, we're going to tell you what we've done. You see my theme? So I think, Jim, your question's spot on because EMS has historically kind of reacted to the healthcare system. We have, we've carried out some of the initiatives that were important to them. This is a great great opportunity for EMS to bring stakeholders in. Just as Brent described, bring the stakeholders in and say, this is a crazy idea, but all of us need to start talking about this. And hey, by the way, it's not one of us, it has to be all of us for that to be effective. So I think we learned from the 12 lead, we learned from Entitled that EMS can be the catalyst. We don't have to own it, but we can certainly be the catalyst to say, come on and sit at this table. By the way, we'll still fix the diversion thing down the road, but I think it's a nice parallel.
I carried two 12-lead monitors during the initial studies of that, so. And then I put one on, then the other, and then I went back to my life packed in.
Yeah, your problem is you got a creepy medical director. That's what happened with that. Other questions?
Hi, my name's Deb Lowry. I'm with Life Fleet. I am in Ohio. My husband and I started the company about 8 years ago, and we've grown quite a bit. However, we are still kind of small. We have 100 employees. We run about 15 trucks a day. And we have been researching this for the last 2.5 years. And our biggest concern is we have, first of all, we're a private company in an area where the fire departments, if any of you are here, sorry, but they don't like us. And so we're running into some problems with our size and them stating that we can't do what it is that we're stating to the nursing homes, to the hospitals, to the hospice centers, to the assisted living centers, that this is something that we can't do. My question was to you guys, as a small company, with the drive and the desire that we have, do you think that limits the capabilities of what we can do in our area?
So I'm so glad you asked that question, and I appreciate your honesty in asking the question, because there is an elephant in, and all of us have talked about this, there is an elephant in the MIHP room, isn't there? Who owns MIHP? For American Medical Response, we should own it, right? I'm the fire service, we should own it. You're nuts, the hospitals ought to own it. Are you crazy? Home health is in that space. That's ours, we've always been there. Small private or big private? Hey, you county systems, you should own it, it's in your area. You see my point? And by the way, standing here, I can look at your observations of me and I see the discomfort, right? How many of you feel like that's kind of a discomfort, it's an uncomfortable thing? Raise your hand. Come on, help me out here, will you help me out for crying out loud? Jiminy, correct. So your question is spot on, because just as our trauma colleagues, our surgical colleagues learned so well and taught us, you can put Humpty back together again much better when Humpty has the EMS pre-hospital side, the dispatch side, the surgical side, anesthesia, the nurses, the chaplain, the ICU, the rehab. The patient does a lot better. And if any one of us tried to do what the anesthesiologist did, and we're not anesthesiologists, the patient suffers. So I think the message, and I think one of the messages you'll hear a lot today, is the only way for mobile integrated healthcare to work, the only way, is if we all realize every single one of us has to be a part of that. You can't take the anesthesiologist out, you can't take the nurses out, you can't take the members of the system out. So nobody should drive and own it. It should be a coordinated practice of medicine for it to succeed. And here's my worry. Critical care paramedics. How many of you are critical care paramedics? So remember what happened in EMS with critical care paramedics. We lost our opportunity to unilaterally own what that entity was, right? There were all sorts of different curricula, standards. So in many states now, a critical care paramedic is not different than an ALS provider, or the flight crew is not different from ground, because we collectively didn't say, as the out-of-hospital practice of medicine, we all agree that these are the parameters that we should function under. So it is a very important narrow window of opportunity, I think, for us right now to get our collective acts together and say, we, meaning field providers, should own this together. So our colleagues from Medtronic Philanthropy sent a fascinating New England Journal article out from 4 days ago. 4 days ago? It's an editorial comment in New England Journal, and it says, What's the missing piece of the puzzle in healthcare reform? Community health workers. And it went through and it talked about how community health workers were representative of their community. They were a workforce that was available. They could go everywhere, on and on and on. So we had a discussion and we said, search for community health worker, replace with EMT/paramedic, and all of a sudden the same principles applied. But that's New England Journal of Medicine. So the reason I think your question is so pertinent is if we try and create this as I own it, small EMS owns it, fire owns it, hospitals own it, we'll look back and we'll go, God, we missed the boat, because someone else is going to get organized and say, you all are fighting amongst yourselves, we can do it better. Let us pray. Sorry, I didn't mean to. Does that make sense? Sorry. I think your question is spot on.
So if I could just add to that, Ed. A couple years ago, I learned about two terms, and I think Jeff can probably provide some clarity about what this actually looks like in real life. The term is interprofessional, and that's different than multidisciplinary. And I think one of the key differentiators between mobile integrated healthcare and a lot of other sort of EMS-driven programs that we've talked about before is interprofessional requires you to leverage the professional expertise of a variety of non-EMS participants in an integrated practice model. And that's something that's uncomfortable for us because we want to drive the dialogue in our communities, but we can't do it alone. And so if you're small, if you're an EMS provider, perhaps you might find some value in exploring other professionals, so professions being medicine, nursing, EMS providers, pharmacists, social workers. In addition, different disciplines within each of those professions. So within medicine, there's cardiology, primary care, emergency medicine, et cetera. They all have something to add. Similarly, you might actually go to the fire-based providers in your communities and say, how might we collaborate with you to solve some of the challenges and the needs in our community, as opposed to trying to do it by yourself? And the reason that we found that to be successful in Chicago was because each of those groups brings a different set of skills. They also bring different sets of revenue under a fee-for-service model, and they also they extend the reach of each provider individually into a new collective model.
Dennis Murphy, Mobile Healthcare Network, Eugene, Oregon. Is there a role for what I call new telemedicine, because it's evolved incredibly in the last 2 years into devices that weigh no more than 20 pounds and are smaller than a lot of our cardiac equipment, transmit virtually every physiological piece of data that is done intensive, just anywhere, all the way up to and including ultrasound, which is transmitted. Is there a role for direct online physician supervision for the higher order of illnesses and injuries that would reach beyond the protocol that would normally be part of a practice of an advanced practice paramedic, or if you will, a community paramedic, allowing safe and economical treat and release services that wouldn't otherwise be available? And one of the partners with that telemedicine is clinical decision support systems, which are built in. So those are two extraordinarily high-tech tools. They're there. They've been used in other countries. Is there a role in your mind for that sort of equipment?
Dr. Beeson?
Yes, so there is a lot of telehealth, telemonitoring technologies that are out there and exist for various disease processes. Heart failure is probably the one that's well known. There's multiple companies that have in-home monitoring devices, scales that tie to Bluetooth technology with blood pressure, with everything else. And for a subset of population, that works well. But the problem is that we're still missing the in-home evaluation that we pick up. For instance, we had a patient in Fort Worth who was literally a rocket scientist, okay, who had heart failure that kept going back to the hospital. And they could not figure it out. This guy's got a PhD. He's a freaking genius. But when we went to the house, what we realized is he's legally blind. And so what he has done with his pill bottles is put the initial of the medication and the number, how many times a day he takes that. And when we did an in-home medication reconciliation with him, we realized his Nexium and his Lasix pill bottles were switched. So his stomach was fine, but his fluid levels sucked. So there is no technology that can pick up things like that. But as far as telemedicine, advanced monitoring, interaction, sure there is. But I want to be very clear in this, is that in some populations where Dr. Wilcox works, great need for that in a rural setting. In our case, not so much that the actual physician is going to add something to that, because I'm very clear in Fort Worth, I do not want to replace primary care. And if we educate people, we train them very well to call 911, and you don't even have to go to the ER anymore. We will bring it to you and we provide everything for you right here and right now. 20 years down the line, we're going to say, well, shit, we did that wrong, didn't we? So it is educating the population how the healthcare system works and navigating them through that. But I do think telemonitoring, telehealth is a huge piece in certain populations and in certain subsets of where you live, topography.
And just to echo that from the Wake County perspective, our congestive heart follow-up has been so robust from the hospital, we have very little to add to that, but it is done with a scale that sends the weights in every day to the health nurse who is monitoring that, and we have been alerted when certain patients are way off, and then we need to go maybe perhaps check on those individuals. So something very simple of a telemedicine of a weight on a daily basis doesn't have to come to EMS. It goes to the nurse at the hospital, but then we sit around the table with them about their CHF patients. So that's another way of very simple utilization that has worked well in our situation.
So as a broad theme, I think that falls under the technology that's required to support this new practice. We certainly should think about that as a spectrum, and as the practice evolves, as the care teams become richer, we'll need more sophisticated technology to support that practice model. When we really think about what are the core competencies that EMS, regardless of whether you're private, whether you're fire-based, whether you're third service, what competencies can we leverage more effectively to coordinate care and to solve health challenges in communities? We can take our core competencies in need-matched, time-appropriate resource allocation, which is what we do every day, regardless of whether you're doing interfacility transport or you're doing 911 response, and use technology to support a physician presence in those encounters, to perform remote monitoring, but it's a spectrum of technology. On one end, there is high-fidelity streaming video from a patient location, and on the other end, there is the traditional telephonic and radio-based communication that many of our systems have infrastructure in place. Leveraging what we have today and growing and evolving the technology to support a new practice is going to be absolutely critical. And I agree, I think we have some technology today, but we probably don't have all that we need. And decision support, as you underscored, is going to be absolutely critical.
I
I have a question.
I don't have a question.
He has a question.
Dennis, one of the other components to your question is what exactly is telemedicine of today? So when you look at the potential, the possibility of what telemedicine could do, so there are devices out there that every morning, it's basically I'm good? We're not good?
I don't think
Can you guys hear me?
Yeah, we can.
Sorry, I know that. So, just kidding. So, there's technology out there that I can put beside my parents' bed that every morning, that's their alarm clock, and it wakes up and it basically asks them questions. Are you short of breath? Yes or no. Did you take your medicines today? Yes or no. Did you climb down the stairs? Do whatever you want to do. No. That algorithm then goes to a monitoring center and says red, yellow, green. Hey, look, Mrs. Rock is short of breath today. So it's not a physiologic monitor, it's a questioning system. So it's a remote telemedicine questioning device. So I think particularly in mental health patients, there's a real interest in that patient population being able to say, how do you feel today? Do you feel better or worse? Do you have, are you hearing voices? Did you take your medication? Do you want to hurt you? All those kinds of indicators. So I think even what we're gathering is changing as As Eric pointed out, I mean, anyone in the room, several of us have Clear C on our phones. We video communicate with folks. I think that's going to change significantly and help us in that arena. Sorry.
Thank you. My name is Sebastian Wong. I'm from the San Francisco Fire Department. And two issues. One is a comment to the lady who expressed concerns about the fire service. I think you'll find that the fire departments in this era involving themselves in EMS are going to basically see this mobile integrated healthcare program as a means of survival and something that they need to embrace or they will no longer be relevant. That's my own personal opinion, not the opinion of my department. But one of my colleagues helped develop a high user program that basically sent a lot of patients into appropriate resources that we didn't have to keep sending 911 resources to. And he also helped develop the IRCP curriculum. So we were very involved in this, so fear not. The County of Alameda, where it's going to do a demonstration project in the state of California, where they will basically, two departments, Hayward City Fire and Alameda City Fire, have already put in letters of intent to develop community paramedicine programs in that county. And my college, which I teach, Las Positas, will help teach that curriculum to them. So don't fear them. Don't fear us. We're not the bogeyman.
And just to that point, so in Chicago, the citywide needs assessment that's now underway is a direct result of Fire Commissioner Jose Santiago's leadership to say this is not only important for the fire service, this is important for the challenging patients that plague all of our city agencies and all of our healthcare stakeholders. And you're exactly right. And I think if you keep that open and inclusive approach in your community and you really try to partner with anyone who may be able to have a value or who has a stake in the health of a patient, it's a game changer in terms of what solutions sort of materialize and how you might be able to fund them.
And ma'am, your fire service has a huge infrastructure of stations that can help you. But the question I have for the doctors is about the curriculum, the national standard curriculum for paramedicine. Do you find that is sufficient and satisfying needs that a future community or mobile integrated healthcare health worker will be able to use as an educational base to safely practice?
Boy, look at the time. Boy, did that. Thanks for all your questions.
Loaded question.
Yes, we and all in unison can say no, right? I mean, there's no doubt about that because each of us have developed curricula or either following curricula that in addition to that level of primary education. And it's interesting, in every one of these, it appears it's about 400 hours, give or take, and about half of that is in the classroom and about half of that is in the clinic. And these were created independently based on needs assessment, what we needed in the community, what we wanted those medics to know, and it turns out to be, surprisingly, about 400 hours total.
I think the reality is that a lot of this mobile health understanding of healthcare delivery models from every level is probably something that should be added to every level of health education, from EMT on to paramedic. The problem is that we're already locked for time. And, you know, we had this conversation well over a year ago when AHRQ and the group, many of you are in the room, I apologize if I'm leaving some of you out, they had a roundtable on community paramedicine in Atlanta well over a year ago, I think now. And that was one of the things that came up is that this is missing in initial education. I mean, we talk about 10% of, or 90+% of EMS education prepares us for 10% of our calls, and we're not preparing our practitioners for the other 90% of calls. But how are you going to go back and add this? Because we've already cut so much out of basic education. And I don't know where you add another 400 hours, which is no doubt needed and would benefit all levels of healthcare practice. But unless you want to turn paramedic into a 2-year program, I don't know where you go.
So I'm going to be a little controversial, and I'm going to say that I don't think there is a national standard curriculum. I think that this is a new and emerging space. I think that there are a number of curricula that are out there that have tremendous value, but what we're seeing is that every program is doing something a little different. And while there's probably some common core content that helps reframe traditional EMS practice to support this new interprofessional community needs-based practice, there's also a lot of stuff that's very specific to an individual community. And Minnesota is probably farthest along in terms of having some standardized products, and Gary Wingrove has put out an absolutely fantastic product that's driving a lot of the training in Minnesota. But I'm going to challenge us all to sort of step back and sort of broaden our perspective and say, this is a new and emerging space. What it's going to take to drive this new practice has probably yet to be defined.
So I want to be a little controversial on Eric's controversial piece, because I think, and again, it's an emerging space. One of the weirdest meetings I've had in my career was many, many years ago when I was in a healthcare system. We met with CMS, and we met with CMS to talk about performance-based reimbursement for EMS. So just like healthcare, there are performance metrics, and CMS was exploring that. And the panel of physicians and clinicians that were asking us about performance-based reimbursement in EMS asked these questions. So, is paramedic licensure national? No, we have a registry. So is the registry the same curriculum? No, but it's the same examination process. Okay, so what about EMTs? Is it the same? No, it's different. Are the criteria the same? Can you go from one state to another? No, not yet. And their point at the end of that discussion was there seems to be way too much difference between different levels of providers in different states. And from CMS's perspective, they want a bucket that they can say you are credentialed at this level, and this is the type of individual professional to provide that level of care. So while I absolutely agree that right now we don't know what that curriculum is, I think all of us in EMS need to be very, very focused on the fact that the outside world is going to want to know that there is a similarity between us, even though we may look different in different communities, that there is a reproducible, similar curriculum and set of competencies for this practitioner. And personally, if I'm that practitioner, I want to be able to go from state to state from my professional growth standpoint. So I think we need to keep our eye on the ball, which is we do have to be consistent, or we're going to suffer from the same CCT challenges that we suffer today.
Fred Phillips from San Francisco. Very familiar with our department in San Francisco. It's a legacy department, and your comment is true. I think there's going to be a comment and then a question. Comment is that the legacy fire departments like Chicago and New York or other come from a culture that's different. They believe in firefighting, and they didn't really want to get involved in emergency medicine for a long time. But now it's 75 or 80% of their business. 20% fire, 80% medical. They are going to want to protect their territory, because without it, they're not going to be able to fund everything else that they want to do. So there's going to be a certain negative feeling about somebody coming into what's now their territory in a lot of ways. So it's not going to be an easy situation to deal with, but as everybody's been saying, you just got to go after the people behind it, the doctors and everybody else, to work with them and get through the process. But the question I have is the payment. We know that with all the changes that are coming with the new Health Care Act, everything is changing, and we look at what it's doing to the ambulance services in our country. Rural Metro, as you probably everybody knows, filed bankruptcy. They're in serious financial trouble right now, and they took on a lot of community paramedicine in our area, especially Northern California. They're looking at $4 and $5 million a year fines by not meeting their response time. And I know AMR lost out that contract, which you never should have lost in that case in Northern California, because they understood the process. But with all these large companies coming in and now having a lot of financial trouble, how do you feel that's going to interact with what we're trying to do with mobile integrated healthcare? There won't be money from them to do it, and work together with the large agencies and with what we're trying to do with mobile integrated healthcare.
So this year at MedStar, in our budget we just approved last week, there is 1.5, Matt, 1.6, how many? $1.5 million of revenue that will be coming in from not transporting patients associated with mobile health care. And so it's there. We spent 4 years now. Our executive director, I don't know if he's here or not, will tell you we spent $2 million to get this $1.5 million. But it's a start, because it took 4 years to prove the concepts. But now when you look at, and that's just not one program. That is hospice program, is a patient navigation program with a nurse in the 911 call center. That is a hospital admission avoidance program. And so there are opportunities and there are fundings. No, we're not like Dr. Wilcox and folks in Minnesota that have a CPT code that's billable to Medicare, Medicaid. That doesn't exist today. But as you look to the future of what's happening in accountable care organizations and bundled payments, I'm not sure that it's time well spent attempting to make another hemorrhage source from CMS or Medicaid as much as it is partnering with payers, partnering with hospital systems, partnering with communities. Every community has indigent healthcare dollars, and God knows that they're spent well. And so there are opportunities out there. You just have to find out what's in your community.
And I would also challenge us, we need to speak the CMS language. They understand process measures, right? So my reimbursement in the emergency department, did I give an aspirin for chest pain? Did I get 12 lead EKGs? Is it documented in the chart? Blah, blah, blah. So those are things that I think we can move to very easily, process-based and outcome-based, and hopefully we never have to talk about ambulance response time again, because that has nothing to do with patient outcome and it's never been proven to do so. So if we could say the first defibrillator on scene time, that's what we're going to report and commit to, and now we're going to talk about patient outcome and things that are in the current CMS nomenclature. Don't reinvent the wheel at CMS. You'll never get there. But if we speak the language they're speaking today, I think reimbursement will follow.
You know, it's interesting. So if I'm a hospital, and this is, and Warren, I'm going to ask you because I'll make up the details. You'll have the real details. If I'm a hospital and I have a patient that has a surgical procedure, the reimbursement for that procedure is bundled. So if I do a gallbladder, the hospital gets paid $100 to do the gall. Obviously, I'm off by 1 or 2,000 decimal points. So hospital gets paid $100 to do the gallbladder. If you do the gallbladder and I'm in the hospital, but crap, my sugars got out of control, but that's all right. You sent me to the ICU, you put me on insulin drip for a little while, and oh crap, you didn't, look, the wounds got infected, that's all right, a couple of antibiotics, take care of that and everything. And I'm in the hospital for 11 days, hospital gets the $100. If I'm in the hospital and I'm healthy, and the doctors and the nurses and all the teams we've talked about before know their stuff, and get me out and get me walking, and I can take care of my wound, and I know what's going to happen at home, and I could go home a day early for the hospital. They still get $100, and they have a hospital bed that's opened up for the next $100. So from their perspective, what we say is, you know what, you're concerned, because think about it, the surgeons make rounds in the morning, and if you're not ready to go, let's watch you one more day. One more day is in the hospital. Instead of, you know what, here is the prime paramedic that will make rounds with you, as is happening in Austin, Texas. They'll round with you, send them home a day early, we'll follow up, we'll monitor them. If there are problems, we'll notify the cardiovascular surgical staff. So Warren, did I make up any of those numbers kind of? I'm good. Yeah, so it's $100. So opportunities like that, which gets back to the needs assessment, to go into a community to say, hey, hospitals, do you have a problem we can help you solve? Because we're a new level of provider, and whether we're a fire provider, a private provider, a volunteer, or the hospital, it doesn't matter what we're going to do to help you with your patient. And we have to be innovative, as Brent said. We've got to speak the CMS language and be innovative and say, we're real good with those patients, and we're really good with following up with other healthcare providers, because that's what we've done our entire career. That's our stuff. Rampart, Squad 51.
And so we all know that healthcare reimbursement is a moving target, and we're still firmly planted in fee-for-service. That keeps the lights on today, and we can't neglect that mission. It's our reality. At the same time, there are sort of a multi-prong approach to how you explore this space. Part of it is the optimization of current loss. So how do you recover the patients that you're cycling on X number of times and never getting anything in return. So that's a space to start, and that doesn't typically usually cost a whole lot. I think the next piece is to go to your stakeholders. So when you identify that health need, identifying everyone who has a stake in that health need creates a variety of potential revenue streams today in fee-for-service. Home health is very interested in channeling dollars to both our private EMS provider and the fire department for certain types of patients with certain needs, because they get reimbursed for those today. Long term, we're not going to be able to get payors, whether they're public or private, to pay for anything until we can measure value, right? It's hard to ascribe a value to something that hasn't been established to produce a measurable change in outcome.
Hi, my name is Sherry Pepping. I'm from Superior Ambulance. We're a private ambulance company in Chicago, outside of the Chicago area. And I sit on a state subcommittee looking at mobile integrated healthcare for the state of Illinois. And one of the problems that we're running into is we're running smack dab into our EMS Act. And I come to these things and I hear everybody doing all these great innovative things, but yet we are being boxed into a very small area. I guess my question is, and Eric is on the committee also, we need to figure out how to work within what we have, but it is challenging, and I just was wondering if anyone else was facing those challenges and how you've managed to get to where you're at from where we are.
Jeff, you?
Well, I will just say, we kind of went with some of this in Texas, and it's funny because when you read the act, it says emergency medical, everything relates to emergency medical services, and so then you ask the state holders, so are you telling me that the 80% of calls that we run that are not emergency, do we still fall under that act? And they will stop and scratch their heads, and they're like, well, yes. So you're saying, well, we already do a non-emergency business. We're not doing it. Yeah, we do dialysis. We do all kinds of. We move non-emergency patients every day, and it's never bothered you then. So what's the difference now? And that makes them go back and scratch their heads. I think there's the fear that we're creating this other role or this, scope keeps coming up. We've talked about it a bunch this morning. And I think it's really, was it Brent? Where'd you go, Brent? You're sitting down somewhere. So you partnered and worked closely with your state health department. I think those are conversations that you have to have. I have to put a plug in for God Bless Texas, that we have, delegated practice. And the state, although they have great rules, it's my practice of medicine, and they can go kiss my butt. So no, I didn't say that. Anybody from the state of Texas?
Why do I see that as Exhibit A somewhere? It's just, Dr. Beeson, do you remember in 2013 when you said, sorry, Brent, did you have?
Yeah, just real quick. First of all, we're going to cut Alaska in half and make Texas the third largest state. Okay. All joking aside, we went to the North Carolina Office of EMS and partnered with them from the beginning. And the notion is there's nothing that they have regulatory authority over as far as decision making. Now, if they were sitting here, I would say this, but the state is not smart enough to regulate thought. They can only regulate procedure. So long as you don't change the procedure, in most states, you're going to be okay.
I think there are 50 different flavors of answer to your question. Every single one of us faces that exact issue. So in Texas, Jeff's absolutely right. In Texas, EMTs can do corneal transplants probably once. Yeah. But the Practice Act allows that. Some of our colleagues, and I know Lou's here from California, I don't know if Howard's here, the restrictions in the California laws mean they have to take an approach that's very, my sense is, believe in this process just like the rest of us and have to work in a different structure to move that process out, to be able to change things. So I think, again, we're going to learn from California. We have all already learned from Minnesota. Texas, 911 corneal transplant. There are all sorts of different approaches to this. The more we unify, again, I think it's critically important. The more we look at the science, the data, as Eric brought up, to look at the value, the easier it's going to be for states to do what they must do within the structure. It's worrisome, actually, that some states, and you all know that, some states are actually looking at taking the paramedic function of mobile integrated health outside of whatever the historical EMS regulatory structure is and putting it in hospital licensing or under the medical board or somewhere else. I think there's a risk in that because, again, it fractures us and makes us look so different. Nobody knows what we are.
So just three things to add to that. And again, I think Ed portrayed this as a spectrum of options. And I think long-term, there may be regulatory change that's required. There may be. I think it all depends what you're trying to do, and what you're trying to do is based on what the needs are for the population you're trying to serve. One piece that was mentioned, the New England Journal Health article that described the community health worker. Dual credentialing EMTs and paramedics is something that the city colleges are very interested in Chicago for a number of reasons. It broadens the skill set, it creates revenue streams, and it also is an opportunity for career advancement. The second opportunity is what Brent mentioned in his talk this morning. When we took this, and somebody wrote in a question, what are the legal concerns? You have to get legal to sign off on this. And I think it's part of that same piece. We sold this to the insurance carriers as risk management. So I said, if we can demonstrate that there's a need in our community and our current response is suboptimal and that we're going to craft a response that's better and that links a variety of healthcare providers to the table, then it becomes very hard, again, provided you're not doing procedures, you're just coordinating communication, transferring key pieces of information, which is really a lot of what mobile integrated healthcare is about, and not so much new skills, new tasks, new procedures. We actually got great buy-in. And by keeping it sort of an open dialogue and inviting home health nursing, the legal folks to the table from the get-go, it was well received.
Warren.
So, I'm Warren Porter. I'm with AMR, and I've got about 7 operations doing this nationwide. I got about 4 more coming up in the next 6 months. And when you're talking about how we talk to people and how we talk to Medicare, et cetera, and I'll tell you, a lot of it is they've stole my thunder as they used to. It's all the communication up front. We've started this stuff a year ahead before we actually started it, actually touching patients. It was a lot of get to the meetings with everybody. I came from the fire service. AMR is the big evil machine that's coming into the community. We're going to scare somebody because we're here. And I had to say, we're not coming in trying to take it away from you. We're trying to take care of patients. And we kept it patient-centered the entire time. I'm a clinical director. I'm not a sales guy. But it was all about clinical care. And then we use the 4 C's, and that's my little pitches: communication, coordination, continuity, care, community impact. And that's all we talk about. How can we do this? It's not who's going to do it. I have a couple fire departments that I'm partnering with. We represent City of Arlington when they come out and they do things. We're part of the EMS system. So we didn't try to separate ourselves. And I think that's one of the areas that all of us need to work on, is working together, getting past those silos that I'm private, you're public, you're this, and that. Stop it. We just got to start working together, and we hit patient care, and pretty soon everyone comes to the table. And when he talked about it, we've been able to go to payers. I have private payers talking to me. I have hospitals paying for it because they understand the value of it. We have communities that are paying us to do it. So there's no one way to do all. Be open and flexible in the way you talk to somebody. Don't walk in and say, I only want capitation, because no one wants to hear about capitation. We saved $2.5 million on readmissions and $800,000 on frequent flyers. It means nothing because they go, and does the Medicare pay for it? They don't want, you got to find a way to talk to them, and it's using their language. So don't walk in as an EMS agency trying to sell, this is what we're going to do. Walk in as a healthcare provider saying, we want to help take care of patients, and how can we figure it out? And that's my nutshell.
Hi there, Nathan Herrig with Cumberland Goodwill EMS in Carlisle, PA. We're at probably not step 1, we're at step 0.7 maybe. Last month we got our hospital's CEO, CFO, medical director, and everyone in a room to kind of start planning forward. We established that we kind of want to do a 1-year proof of concept run with this, that there's no real reimbursement for it. It's kind of, let's see how this goes, looking at the 3 major discharge criteria, the AMIs, the heart failures, pneumonias. My question is, what sort of metrics have proven to be most useful to establish that proof of concept, so then you go back and get the funding for it?
Brent?
Yep. So I think there's 3 components of that. The first of those is patient satisfaction, and we're working on that patient experience question, right? I mean, that we've got to get that worked out. The second is patient safety and or clinical outcome. The problem is it's very difficult to show benefit. So it's in that realm that they're actually doing better, but it's pretty easy to show they're doing as well. So as patient satisfaction improves, patients are doing as well, this is safe. And then finally, the value proposition, they are less expensive to the overall healthcare system. And that really is the order in which you evaluate them, I think. Patient satisfaction is first, because we're monitoring the safety anyway. So those are the 3 realms of metric that we're looking at, and we know that is speaking CMS language. That's triple aim language that helps them as we go forward.
I think your metrics will change based upon who you're talking to. I mean, let's be real about it, because some of your payers will have certain inputs. Your hospitals will have something else, because the hospitals will view as you're taking money away from them by not bringing these patients to them, versus the community. So I think if you always put the patient first, kind of like what Eric talked about earlier, the clinical, and same thing Warren kind of talked about the clinical aspects of it. But be prepared when we go, and Matt's the king of this, and he has a presentation. We're talking about our heart failure program. He has 3 presentations, and depending on who he's talking to, depends on which presentation comes up. It's the same information, it's just presented 3 different ways.
I can't emphasize that piece enough. So, by the way, I'm really glad you asked about metrics, because that's where we all need to go. We've got to be able to figure out what they are. If you look at what motivates who, if you had the same presentation to your hospital or to the healthcare system or to the payer or to the community, you would fall flat on your face with 2 out of the 3 of them if it were the same. It's not the same. The product is the same, but their motivator is different. So we met with a huge national healthcare system. Last year, they were hit with $13.2 million in penalties for readmission of congestive heart failure. $13.2 million. For them, it's like a rounding error. It is the cappuccino cart tip thing. It's a huge healthcare system. The CMO told me, he said, Ed, we're not as obviously they are. The $13.2 million penalty, the patients that were admitted that caused the penalty generated revenue that was almost 8 times the 13.2. But he said, we got to fix it, because that data means we have 13.2 million of readmission, inappropriate readmission patients. We drop on the list on the public reported hospitalcompare.gov. Health plans now look to see what hospitals are going to cover, and they say, oh, you readmit a lot. Sorry, you're no longer a participating hospital. So to Jeff's point, that's a pressure point for a hospital to say, it's not the penalty that's driving me. I don't want to be bottom of the list here. And by the way, I want you to prevent those readmissions for 30 days and 1 microsecond, because at 2 microseconds, we'd better check them out. They can get very sick quickly. But that's right. So that's their motivation.
So just to build on that, I think the common theme there is that every stakeholder has a different stake, and in understanding their stake in the value proposition is how you frame it. And so the more people you have at the table, the more you start to understand, because this is like the Venn diagram, and you find where all of the respective stakes overlap, and that's where you start to carve the program. Scott actually told me he came to Chicago, sat down with our CMO at the University of Chicago, and drilled him on just that question. And he candidly admitted that he had never thought about EMS as a potential outreach strategy. And what he said is, these are the metrics that are important to us. Our home health partner said, these are the metrics that are important to us, and they're not the same. They overlap, but they're not the same. These are the metrics that are important from a patient safety standpoint. And then you design a program around those. So with the risk of sounding overly simplistic, part of the needs assessment, part of the coalition building, part of understanding all the stakeholders up front is, what is your goal? What's important in your stake here, so that the program's designed to actually impact that. So the structure, the process, and the outcomes of the program are all driven by the needs of that population.
Hey, Eric, do you want to go to online question?
So there was a good question on here. I'm with a private EMS agency. Most of this has been around 911 response. They're interested in how this space applies for non-emergency EMS providers.
So I'll take a stab. I don't think it matters. I mean, here's the reality. What matters is we develop the professional that has the competencies with the appropriate curriculum and the appropriate performance measures. I mean, if you look at this financially, 1 person in a smaller car versus 2 people in an ambulance is less expensive. However, if you're the EMS system and you have capacity available it might make much more sense to have the on-duty ambulance be the entity that responds. So I think we need to, just as we need to separate the integrated health belongs to one type of our profession or another, I think really whether you're the transport provider in that community or not, it changes the logistics of how it would be implemented, but I don't think it changes at all the value of having that program in a community.
Hey, Brent, I think there was a comment over there.
So what I'll add to that, just on the private side, is we're obviously a governmental entity in Fort Worth, but we are now, especially with our hospice program, moving into areas that we don't serve. And part of that moving into that area is going and meeting with the people who do provide the 911 service and understand what we're here to do, and we make them partners in the process because they really don't want to own it. A lot of them don't want to do it, but they like the fact that you came up front to them, you're partnering to them, and as it grows and their budgets shorten, it's also another thing in the table saying, hey, if you partner with us, we're getting paid to do this, and we will subcontract with you a percentage to do this also. So it's a potential revenue source for them, even though they're not the one that the provider or the organization is actually contracting with. So I think, I get this question quite a bit because we talk about this all over, and I think that these smaller private organizations like the young lady over there are probably the little speedboats that are going to be able to get it up and going, where our bigger organizations like the Chicago Fire Department is, somewhat the I won't use the Titanic because that sank, but a big boat that takes a long time to turn around.
Bigger ship to steer.
Bigger ship to steer. There you go. Thank you very much.
If I could, just in Pittsburgh, in EMED Health's evolution, we started out actually as a network manager for EMS agencies that wanted to do community paramedic programs, and the most responsive EMS agencies were always the smaller privates. They inherently got the potential role for their medics to play in these types of things, and I think you heard a lot this morning about community needs assessments and doing that, and we all hear community and think of a geo-municipality type of community, when in fact we're talking in some regards like a market analysis. If we are serving nursing homes, skilled nursing facilities, other hospitals that have a certain population of patients, then there is a lot of value that we as providers can be, regardless of how we're corporately structured, can bring to that particular population and help. And we actually had a lot of conversation early on with a skilled nursing facility about including a community paramedicine feature as part of their rent. They were going to charge an additional $10 or $15 per month to their residents in their assisted and independent living facilities to have that community paramedic backup, because it was a really cheap alternative and it was a great constant revenue stream for the local EMS agency. They were willing to explore that as a competitive differentiator for their facilities that they could market and bring in more residents. But basically, and they said, and even though it's a price-sensitive market, they thought that would be something that they would be willing to do. So there's a lot of potential market out there for the smaller private companies, for sure.
I think that's a really key distinction, though, that when we talk about needs assessment, it's really a population needs assessment, not a community necessarily. Community is one way to define a population. At the hospital level for our CHF pilot, we define that based on the hospital's population, who they serve, and the CHF patient population they serve. And you should all know that a variety of folks in your communities do needs assessments already, so you don't necessarily need to go out and do this on your own. You can go to people in your community who've already conducted needs assessments and say, might we be able to help you with needs you've identified?
What, Ed? What are you trying to point to me, dadgummit? I can't read your mind.
God. Listen, if we wake you, Jeff, let us know. Sorry. It's always Brian's fault.
Again, one of the things that we learned in talking to people about, and I say community needs, it was really going and asking all of the key players, fire, EMS, hospital, hospice, the nursing homes, and everyone, and started asking them, what is it that you need? And when we talk about metrics and all this other stuff, we actually help them, just like pulse ox and ERs and everything, and Title CO2. They don't know what they don't know, and they don't know how to define it, and we actually help shape all that. So sitting with them and saying, what you really need is, how do we take care of the patient from bouncing back, or what do you need? Everyone will pick CHF, MI, and post and pneumonia, because that's what CMS looked at. I've looked at DRGs in probably 20 hospitals. I looked at all their readmissions. Sepsis is number one, or renal issues are number 1 or 2, and then heart failure and cardiac are number 3 and 4, but CMS is looking, so that's what they're looking at. It's being open and saying, you have these issues, and how can we leverage what we have? And we talk about our core competencies, and I'm sorry, I'm trying to do a lot at one time, but it's how do you get that core competencies? We didn't go in and try to fight with home health because we'll lose because they have much bigger lobbies than we ever could, but we filled niche where they couldn't do it. There's a lot that they don't understand they can't do, and when we came in and said, I'm not going to fight with you, I'm going to look at how we can do it. We actually raised the clinical care in Arlington, Texas by 60% for all homebound patients just because we did our service, and when they compared them to us, we were doing better. And they said, how do we do that? And we said, simple things. Report, follow through, do all these things that we know we can do, and stop looking at us as an adversary and start working together. And really, a lot of everyone's talking about the same thing. It's communicating with people and then looking and saying, you have a need, and how can I make it work? And we're not very good at that in EMS and the fire service. We can come in and say, this is what we're going to do for you. Here's our square peg going to your round hole, and you're stuck with it. And you got to kind of change your mindset and say, what is your need, individual hospice? And I've been to community organizations where they've had 250 community people in one room, and it takes 5 hours for people to get to one common definition that we can work on. So it just, everything we're saying, we've got to do the legwork ourselves and kind of be the ones that start the conversations that bring everyone together.
Warren reminded me, this is a dirty little secret that we don't talk about a lot in mobile integrated health, but I'll ask my emergency physician colleagues. There is a group of physicians that really doesn't like this concept of mobile integrated health yet. Emergency physicians. It is us. So just as we have the same discussion, so now all of a sudden we're going to emergency physicians and saying, hey, listen, we're going to do a program on CHF and pneumonia and MI readmission reduction. We're going to keep your emergency department clear. No more nasty bills, no more, oh, crap, wait a minute. That's how they generate revenue. So everybody has, as you very nicely said, everybody has a stake in this. Emergency physicians could see mobile integrated health as taking their patients who come to the emergency department and taking them to an alternate non-emergency department site of care. Similarly with hospitalists, if we decrease hospitalizations, then all of a sudden, hospitalists who are paid on volume have less patients coming to the hospitals. Maybe wards contract, maybe census drops, so there isn't a need for hospitalists. So I think as part of this, remembering where everyone's stakes are, remembering that the emergency physician has a key role in a community to help potentially, and Dennis, it gets back to your question, potentially help with some of the triage, who can go where, who shouldn't, I think is important. So even that side of the House of Medicine is still trying to figure out from a professional standpoint, what's this impact going to have on us? Did I miss it? Did I misrepresent?
Of course you did, but that's okay. We expect it.
We turn the mic off. Can we just turn his off? He's not.
Ed, just to follow up on that, I've got 5 stakeholders that subsidize my 911 service. And I'm sitting here trying to figure out if there's enough money in this to help subsidize my 911 service. But as soon as I take something like this back and present it to my board and my 5 stakeholders that are supporting my 911 service, their first question is going to be, oh, so we're not going to have to subsidize you anymore. So I'm kind of curious if there will ever be enough money in this community paramedicine to subsidize the 911 service. Should it be subsidizing it, or should we still require my stakeholders to keep pouring in the money like they've been doing?
I can tell you for us in Fort Worth, we don't have subsidy. And the beauty of that is now it forces us, number one, as a business to look for alternative sources of revenue. But number two, when the cities are $50 million in the hole and all the fire departments and police departments are having to cut budgets, they don't pay us anything. So we end up like the golden goose laying the egg. And so I think I have talked to multiple rural providers. I believe, yes, this is an opportunity to sustain the existence and the need for readiness. In fact, when we were in D.C. last year having conversations with ASPR, who's all concerned about readiness, they'll be the first to tell you that our current model of providing emergency medical services is not sustainable. And so we have to look for other sources of revenue and other ways to bring in money so that we can be ready when you get in the car accident on the freeway and you do need the things that we claim are our specialties. And so I would suggest for you, your goal is to find as many other sources of revenue that you can to decrease the cost to your stakeholders, because you have just made it more of a concrete foundation to your stakeholders and what you provide for them other than medical transportation.
So just to build on that, there's a key perspective that I would offer, and we found it very useful in our experience, and that is try to avoid talking about revenue and try to talk about value, because value is something that is a relative commodity, and if you design something on a value basis, you can create something that has value for all the stakeholders as opposed to just value for you. And that comes back to the different slide decks for your different stakeholders. So, on two sides of the same coin, value is doing more with what you already have, so taking existing capacity and squeezing more out of it. The other side of the value coin is doing something so well that it adds so much value that you can establish the market price for that. And if you craft a value proposition that includes all your stakeholders' value propositions as part of it, then you diversify your potential revenue streams and create sustainable funding. Does that make sense?
So let's take one more. Oh, sorry, go ahead.
My name is Alan Vartan with Kaiser Permanente, and measurement strategy answer you guys gave is completely aligned with our triple aim focus and our exploration of community paramedicine. One question, and I'd love your suggestion, is especially for the complex care patients where there are multiple programs touching these patients, how do we differentiate the impact the community paramedicine program had in ED, hospital admission and readmission avoidance versus the impact the other programs had? And how do we do that in a systematic way that's not dependent on laborious clinical chart review?
Eric, do you want to?
So I would start by saying I think that you just summed up the theme of the day, which is that it's not just about community paramedics, it's not just about EMS, it's about the team. And just as we know it takes a village to save a cardiac arrest patient and to realize a good outcome, and each link is critical to success, same thing with almost every mobile integrated healthcare project I've ever heard of. And that is that you need a team of people with different expertise, and they need to be linked together to really impact the outcome. And I think that if we can start to move the dialogue from this is an EMS exclusive initiative to this is a collaborative initiative, and in some communities EMS may drive the dialogue, and in other communities home health may drive the dialogue, and in other communities community health workers in the public health department may drive the dialogue. I think that there's then a framework that looks similar anywhere you go, but the particulars are a bit different.
And I would echo, for us, a shared savings model is the best approach. It allows us to go to that provider, and for a particular patient type, 90% of the control may be the CHF nurse at the hospital, as in our community. We give a very small amount to that overall enterprise. So as a shared savings model, the hospital would get the bulk of that money, we would get a little bit. Conversely, the mental health patient that we keep out of the ED and decrease those costs, that is mostly on us and a little on somebody else, but allow the locals to work out proportionally how much of this overarching thing am I contributing to, and we'll work out the shared savings amongst ourselves. Seems to be a fair approach.
I think a beautiful thing that we have seen, Mike has seen it in Minnesota, I'm sure Dan has seen it, we've seen it in Fort Worth, is that our medics, our providers, these are their patients. I mean, it's almost like a family. I mean, and there's ownership in that. And I think in a lot of huge health practices today, that ownership and relationship is gone, and it's just another number. It's just another, so when you talk about complex diseases and complex patients, somebody has to have the ownership in that, and somebody has to have the want to succeed and the patient to do well. And we can come up with all the healthcare plans, and we can involve all the specialists to come up with a beautiful scientific-based, care plan. But if the patient doesn't have a buy-in or ownership in that, it's not going to work. And so I think it's truly this whole team integrated approach, including the patient, not just the healthcare providers.
and I'm not sure what this says about me, but right before the end here, Joan has asked me to remind you that there are cocktails in this room starting at 6 o'clock. And so, right. That's the real solution
There's
to all
a
this.
card.
All problems solved over cocktails.
There's cards on your tables, I believe, little
Right,
white
to
cards.
remind you, just make sure to look at those, and they'll be right in this same room at 6 o'clock, and the best kind of cocktail is going to be here free.
And you will be led by Dr.
Right.
Eric Beck. Not sure where he's leading you, but...
So, thank you. We're going to wrap things up. Thank you for the morning. Thank you for being interested in this, being there along the journey. It literally is a journey. This journey is probably more important than our destination. A lot of great dialogue this afternoon. You've got a lot of great speakers. Thanks again to our sponsors, Medtronic Philanthropy. And we will, anything else from the panel? Okay, we'll see you at cocktails at 5:30.